All right, facial trauma. So facial trauma is a very common call out for the ambulance. Normally it's not very severe, to just be, assaults and whatnot, but occasionally they can be very serious, as you can see with this image here of someone whose face has been entirely destroyed. Facial trauma is of particular note because it causes a lot of patient anxiety due to concerns, cosmetic concerns about appearance. Having, terrible scarring on your face is not ideal, but also just day-to-day activities like eating, talking. No one wants to be drinking through a straw. The patients will typically be very anxious about these sorts of injuries. So in severe facial trauma, you can have a pattern of injury which are called Lefort fractures, and they're in the picture down the bottom. So Lefort 1, which is where the fracture has occurred over the lower portion of the face and has actually separated those two parts of the skull. The patient will have obviously pain, but they'll also have numb upper teeth and an unusually mobile upper jaw, whereas normally only your lower jaw is mobile. If you move to Lefort 2, the light blue one, you can see the fracture is occurring higher up and now including the nose. So you will again have pain, you'll still have the numb upper lip, but now the nose will also be numb due to damage to those nerves, and instead of just the upper jaw being mobile, the entire midface will be able to move around as you would expect if the skull had now been separated into those two pieces. Lefort 3 is the most serious. So this is where the fracture, the skull has been split into two pieces right across the top of your eyes. Again, pain, but this is where people will start to have difficulty breathing, as well as marked facial deformity and a lot of swelling. The reason they'll start to have trouble breathing is because now all of the structures that help hold your tongue and your other soft tissues forward off the airway are losing their structural integrity, and they can start to collapse backwards. Now, orbit fractures, so the orbit is the bony soft tissue and bony areas that surround your eyeball. So you get hit in the eye with like a cricket ball or something like that, you have very hard bones to protect your eye, but that force will get transmitted through the back of your eye socket and can result in what's called an orbital blowout fracture, because you have much weaker bones around the back of your eye. So the force can be transmitted through these strong ones, and then it blows out the back ones. There's not much you can do about it. It's just ice packs to reduce the swelling. Important that the patient avoid nose blowing, vomiting, things like that, because they can start to get air. Air moves pretty freely through a lot of your head, and it can actually start to build up under the eye and start to cause pressure problems. Now, eye trauma differentiated depending on the type of the trauma. If it's trauma that just involves the surface of the eye, it's just continuous irrigation with either saline or water until the patient feels that whatever if they had a bit of glass in there or something, if they say, I think it's out now, then you can stop. If the eyeball has been penetrated with something, as you can see in that bottom image, you try to protect the eye without putting any pressure on the embedded item, and a styrofoam cup is ideal for that. You want to position the patient semi-recumbent, so that means sitting but not upright, sitting but laying back a little bit as you normally do in an ambulance stretcher, and give the patient an antiemetic such as ondansetron or Maxilon to stop them from vomiting. If the eyeball is extruded, which means if it's hanging out, don't try and put it back in, just support it with a saline soaked dressing, tape it in place, and then a rapid transport to hospital. Now, nasal trauma, again, very common with assaults. The only real intervention from us, again, is ice packs to keep that swelling down. Nosebleed can be really serious. I've been to a few older people in my career who've had such serious nosebleeds, they've actually become hypovolemic from it. The ambulance management just involves getting the patient to lean forward so that the blood isn't running down the back of the throat. That will cause them to vomit eventually, which will cause more problems for you. So have them lean forward so that the blood drains out, not down, and they just pinch the soft part of the nose until the bleeding stops. Now, that will work for the vast majority of nosebleeds. If it doesn't, they'll need to go to the ED for nasal packing or balloon inflation up the nose just to help compress everything in there. Jaw fractures, again, common in assaults. Very, very painful. and requires a surgical repair. There's really nothing we can do for it. Just ice packs keep the swelling down, pain relief, and having a soft collar may just provide some stability for the jaw and help hold it in place. Patient may not like it, make that decision at the time. Now with dental trauma, again, assaults, very common. You may find a person who's had their whole tooth knocked out and they've got the tooth. If it's only been an hour, which it typically will be for an assault since the injury, you clean out the socket with give it a saline squirt, clean the tooth with a bit of saline or water, and then put the tooth back in. It's not just going to suck in there and stay there. They're going to have to hold it in there for several hours. So give them a pad or something and just hold the tooth in there for several hours, and it should retake. The periodontal ligament should reattach, and the tooth will be fully functional. If for whatever reason patient can't, doesn't want to do that, or for whatever reason you can't do it, store the tooth in milk, saline, or just in the patient's own mouth in their own spit. Don't put it in water; it will destroy the tooth. For children, we don't re-implant baby teeth. They're going to come out anyway. It just means the kid has a bit of a gap for an extra year or so before the adult teeth come through. If the tooth hasn't come out cleanly, if it's just broken, there's nerve bundles in the center of your teeth, and very painful if they're exposed to air, so try and cover it. And blue tack is actually really good for it. If you can just blue tack over the tooth, it just molds to the shape. If you don't have blue tack, cover it with whatever you can. Now, airway management in trauma is a bit of you can end up with some conflicting points. So patients who have significant facial trauma, you're obviously also worried about their neck. They've had something enough to break the bones in their face. Some of that force is going to have been transferred to the neck too. So you ideally want to manage them as a spinal patient, which would mean collar, and supine positioning. But facial injuries bleed, and if you're forcing someone to lay supine, they can't passively, like I said, for the epistaxis, you want them to lean forward, drain the blood. So you have a little bit of a push-pull dynamic into what you're going to do there. The answer is actually very simple. Airway always comes first. Now, if the patient is conscious, as I said, you're just going to want them to lean forward and manage their own airway. If that means that you put a soft collar on them and they lean forward and manage their airway, that's better than nothing, isn't it? And that might be what you have to do. If they're unconscious, you have two options depending on what state you're in. If you're in Brisbane, Victoria, or any other places that do rapid sequence intubation, that would be a good patient to intubate. Someone who you want them to be supine for spinal management, but you also need to control their airway. Putting them to sleep and intubating them is the ideal solution there. But if you're in a state or a city where RSI isn't an option, you're just going to have the lesser of two evils and manage them laterally, acknowledging that that's not perfect for spinal management, but airway comes first, and that's going to let you manage the airway. They're lateral, the blood will be able to passively drain, and you still be able to ventilate them quite easily with a bag valve mask. If they have facial fractures, as I said, like with the Lefort fractures before too, they may lose the ability to manage their tongue. So even if there is no bleeding, having them supine, the tongue will fall back against the back of the throat. Again, you're just going to need to manage them laterally. These patients, if there is significant facial bleeding, will be intubated at some point, most likely. So if you can't do it in the ambulance, have consideration for how much time you're spending on scene, knowing that needs to happen, and it needs to happen at the hospital. Now, your head is very vascular, your face is very vascular, and bleeding can be quite pronounced. The nose bleeding, like I said, we just try the pinch, but if that doesn't work, in the ED, they can pack the nasal cavity, and they can also pack against the hard palate and any other areas that can bleed a lot too. Again, that's a hospital intervention, so if you can't control a bleed, do have some thought for just an earlier transport. And that's it.